we would like to give a huge thank you to our sponsor tonight, Memorial Neuroscience Institute, and please welcome Nirupa Valdiosing.
Hi, everyone. Very nice to meet you all. Thank you so much for having us. We're really excited to be partnering once again with the Epilepsy Foundation. And it is my pleasure. Should I go ahead and introduce Dr. Barr?
Yes, please.
All right. It's my pleasure to introduce Dr. Barr. He is actually one of our newer neurologist who features with epilepsy, and so we're really excited to have him join us today. He is a neurologist at Memorial Healthcare, specializing in evaluation, diagnosis, and management of epilepsy. When he was a child, his father was diagnosed with mesial temporal lobe epilepsy with frequent seizures, with staring and lip smacking. It was frightening and sobering to see such a fragility to the man who has always been a model of security and strength for him. This personal experience has provided him with a unique insight into what family members and patients with epilepsy are experiencing. It inspired him to pursue a career in neurology and epilepsy care, where he can help others who are facing similar circumstances. Each person has their own story to tell, and epilepsy can impact their lives in different ways. It's a privilege to help improve the quality of life through management of the condition and common comorbidities, such as mood disorders that can often be overlooked. So it's my pleasure to introduce Dr. Barr.
Hey, thank you guys. Thanks for that great introduction. It's nice to be here. So we're going to be talking about neuromodulation and drug-resistant epilepsy. So I've got a little presentation here set for you guys, so just give me one moment.
And while Dr. Barr is looking for that, I also want to introduce Dr. Katani. Dr. Katani is board certified in both neurology and epilepsy by the American Board of Psychiatry and Neurology, practicing at Advent Health Tampa. She is a member of the American Academy of Neurology and a member of the American Epilepsy Society. She is currently an active board member of Epilepsy Florida, and she focuses much of her efforts on improving the patient experience and providing care for underserved populations.
Thank you for your kind introduction, Rachel. And thank you, Dr. Bart, for being here today. We appreciate your time and your knowledge. Thank you.
All right, thank you guys. So again, we're going to look at neuromodulation and drug-resistant epilepsy. I have no disclosures. I'm one of the epileptologists at Memorial, as you said. And kind of what are the things we're going to be looking at? We're going to be defining what exactly is drug-resistant epilepsy, what is neuromodulation, and then we'll go over some of the devices and the selection for patients. And of course, any questions, we'll talk about those afterward, and then we'll just discuss the response to the different neuromodulation therapies. So, the first question is what is epilepsy and the backstory. So what is a seizure? It's a term that we use to describe an event characterized by, we have stereotypical signs and symptoms, which are abnormal and excessive neuron activity in the brain. So they have the same what we call semiology, same presentation for patients, and they can also vary depending on where these seizures may be coming from. And then the question is, someone has a seizure, but what about when someone has epilepsy? We use these at times, it seems interchangeably, but when someone has epilepsy, it means they've had 2 seizures separated by 24 hours that were not provoked. So it wasn't because they had a low sodium, or that they had withdrawal from alcohol or benzodiazepines. And so they've been separated by 24 hours, or if they have an injury on the brain imaging. And as well, if there's some variables, if someone has a seizure that occurs out of sleep, that's a worrisome sign at times. And then if they have abnormalities on their brainwave test. So furthermore, how many people actually have epilepsy? How common is this? So over 70 million people worldwide suffer from epilepsy. And is it more than just this abnormal electrical activity and the shaking that we see? It can also present in other symptoms. But it also, in addition to that, we have a risk of other conditions such as mood disorders, cognitive changes, and that can have a a very profound impact on someone's quality of life. And so what's the first line that we treat? We treat them with medications. So typically, about 50% of patients will be controlled on one anti-seizure drug. And then about another 11% will become seizure-free when you combine or add a second medication. And then about 3% will be controlled after failing a second agent. So that third medication, you're only getting a small, it doesn't have this great additive effect each time, it gets less and less. This has been really well unchanged since the early days. We really have an improvement in the side effect profile, but the effectiveness has still remained about the same. So we have really remaining about 30 to 40% of people with epilepsy will be diagnosed with drug-resistant epilepsy. And that's the failure to achieve that seizure freedom after 2 trials of appropriate dose anti-seizure drugs. So we failed the medication side. Now what's our next step? So the next step would be sent to a higher epilepsy center, like we have at Memorial, the level 4 epilepsy center, and we would be evaluating for a surgical treatment. So resection, which is a removal of one or more of the lobes in the brain, or we can do a laser ablation. There's also lesionectomies, which you are moving a small lesion, or what's called a topectomy, which is part of the person's frontal cortex in the brain. So we aim for seizure freedom entirely, and it's a curative. It is not always curative. So about 50 to 60% of people who undergo a temporal lobectomy, which is one of the more commonly and more well-studied epilepsy surgeries, about 50% will remain seizure-free after 10 years. So it's not 100% in a guarantee, which is an important thing to know and to discuss as you're planning forward. If epilepsy surgery is something that's being considered. When people have a frontal lobe, which is the front of the brain, about 30 to 40% of those patients will remain seizure-free after 10 years. And so not everyone is always a candidate for the surgical resection. And what does that mean? It means that they have a seizure where the seizures are originating from is coming from an area of what we call eloquent cortex. That's a fancy term for saying it can cause trouble with movement, with sensation, with vision, or it can also cause issues with language, depending on where the origin of these seizures are. Or if they have multiple lesions that we can't remove. Or lastly, if you have seizures, but we are not able to really identify where exactly are they coming from. We have a lot of different options for that evaluation, but sometimes we can't narrow it down exactly to one specific spot. We don't want to be taking out big chunks of brain. We want to take it as minimally as possible. So what then? So we can't have the surgery. Are we done? Do we give up? Fortunately, we've come with some appropriate treatment now with neuromodulation, and that's been a promising treatment for those patients that have the drug-resistant epilepsy. So again, the surgeries, the goal we're aiming for it to be curative. These treatments is to improve, but they're not expected to cure the seizure disorder. So again, understanding the expectations. And here's a little tabular format with the chance of seizure freedom and the risk of cognitive changes. So adding medications, you can slowly, if we go beyond those 2 or 3, that chance of improvement is going to be much lower. And then the cognitive risk can be additive. Here we have the neuromodulation, which we'll talk about. And then we have the surgical resections or ablations. And so we're talking about neuromodulation. Might be helpful to know what exactly is that. So it's electrical stimulation, sends a small electrical signal to a part of the brain, to affect or reduce that abnormal electrical activity that we have when someone has a seizure, wherever it may be coming from. Anywhere. And this neuromodulation, the stimulation can be sent to us from a number of different locations. So we have a peripheral nerve, which we'll talk about, in the vagus nerve. It can be in deeper brain structures, or it can also be on the cortex, which is the surface of the brain.
What, Valley? What are you gonna buy?
So we'll go to the vagus nerve stimulator. And what it does is it sends you have electrodes around the left vagus nerve, which is it kind of goes down the side of your neck and your throat, and that sends a signal up to the brainstem, up to these structures called the thalamic structures in the brain. And it has a generator where it gets its power is inserted just above the left chest and goes beneath the skin. And there's a couple of different modalities that we use. So there's one what's called an open loop, which means it has a continuous signal that it's always sending up the vagus nerve, and you have a magnet. So when someone is having a seizure, you can wave the magnet over it and it provides an additional impulse to it. And then we have a closed loop, which, what does that mean? These are fancy terms. It means it's sensing the changes, in this case with the electrocardiogram, and it notices changes in the heart rate, and it'll provide stimulation if this set threshold is passed. So we have set parameters, and if the heart rate goes above or beyond that, then it'll provide a little electrical current. And we also have the magnet available, so that can give, again, an additional stimulation. And so VNS, that was approved back in our old days in 1997, and it's been effective for focal and generalized epilepsies. So we have focal epilepsies, which is there's a single, or you can have multiple areas where there's abnormal electrical activity that can then spread to other areas, or generalized epilepsies, which is the whole brain is being activated together at once. And with VNS, about 50% of patients or more than can achieve some seizure improvement over 3 to 4 years. And that's about 40% of people. So keeping in mind that these are the expectations, that these are not always going to be curative, and not everyone's going to respond in the same way. And so VNS also has some additional advantages from the standpoint of it's not just improving the seizure frequency, but it also has some antidepressant properties. So when we have someone who has a mood disorder, they've actually used the VNS to treat drug-resistant or treatment-resistant depression. So it's a different condition, but treated in a similar fashion. And then it also has a decreased risk of what we call SUDEP. SUDEP is sudden unexpected death in persons with epilepsy. And that's one of the things why we are so vigilant about trying to improve someone's seizure frequency and reducing them. And ideally, our aim is always to prevent them altogether. But people that have epilepsy are at risk for this sudden unexpected death in people with epilepsy. And that's why we are, why we have these epilepsy centers that we're at to, once you fail the medications, what are the other options? And so who is a good candidate for vagal nerve stimulators? And over time, they reduce the age. So now it's kids 4 and older can have the vagal nerve stimulator. And then, of course, you have to have drug-resistant epilepsy. It's applicable in people that have said focal, maybe it's coming from one area, or it could be what we call multifocal, which means there's several areas, but it's coming from those specific areas and then spreading. And these are again for patients who are a poor candidate for a resection or an ablation. Some of the side effects that we can experience with VNS is you can get hoarseness and a cough. Sometimes you'll have your voice can change and have throat pain. It can worsen obstructive sleep apnea, and also it can at times be associated with some heart arrhythmias. Next, we have our responsive neurostimulation, and this was approved in 2013, and what exactly is it? We implant these small electrodes into the brain, either using a strip or the individual electrodes. And it is a monitor for seizure activity. So it is not like the original VNS that we spoke about, where it's always delivering a continuous current, but rather it only delivers current when it detects the start of a seizure. What is unique and interesting with the RNS is that it's programmed for the specific features in that seizure focus. So again, we're looking at it's coming from one small specific area. Those settings can be adjusted by the epileptologist, and it has a remote that actually transfers the data from those electrodes in the brain to a cloud-based system, and we're actually able to review the frequency, and if people can have both what we call clinical, which are the seizures that people experience physically, or if they have the shaking, or it can also be subclinical, where you're not having the symptoms, but there is abnormal electrical activity that's activating, and it's not hitting a part of the brain where you experience the symptoms, but they can still be, that's still that abnormal electrical activity. So it's we place the implant is into the skull, and then that connects these two leads, so two wires that go down into the brain, the locations that we want to stimulate, where we have identified as the location of where those seizures are coming from. So a simple summary of what does RNS do? It records, it detects seizures, it responds to when a seizure is developing, and it sends a stimulation, a little electrical current, to try to reduce and prevent that abnormal electrical activity from spreading. Again, that's what we discussed as far as it preventing that. It disrupts the synchronous activity for those neurons in the brain that are going to be building up and then presenting in the seizure and spreading out through further areas where you experience the symptoms. It can also change the blood flow of the brain within the brain, not in the sense of it causing strokes and cutting off blood flow. It's these very subtle changes. Some of the long-term effects is that it can actually change some of the way the brains. We're pretty well set how we are when we're adults, but we do have some ability to adapt, and it can change the way that the neurons are interacting, and over time it can actually improve the seizure frequency. Even it's not like a medication where you start it and you get to a certain dose and you've tapped out. There's actually an improvement more over time. So that first year can be different and often better than the second year, third year, and so on. Here's a little tabular image of the people their response rate, and then also the reduction in the seizure frequency. The gist of this is that the greater than 50% of people are going to respond after the second year. And how effective is it? And so in that first year, people have up to around a 40% reduction in their seizure frequency. In the second year, it's 53. The third year, we're up to 60. And by year 6 of those long-term studies, we found that it can have about and this is just an average, the median is about 66% reduction in seizure frequency, which can be a profound change when you're thinking about someone who has frequent seizures, or it's impacting their life, that you're losing that really the predictability of life. If you're having seizures frequently, you don't know when it's going to happen, and now we're able to reduce that, provide a much improved quality of life. Furthermore, when people can actually have long periods of seizure freedom, which sounds like, oh, only 6 months, but when someone's been experiencing seizures for several years, that again has a pretty significant impact on their quality of life and their experience and what they feel comfortable doing and not doing. With the RNS, so people will have about, again, 13% of people can have up to a full year of seizure freedom, which that changes the ballgame. Again, this is just a tabular perspective. So with RNS, it's a safe procedure. It has about the risk is being comparable to patients who have undergone the resective surgery, like we talked about. Those are the ones that were good candidates. It wasn't affecting eloquent cortex, a location where it's going to affect someone's ability to see, the ability to talk, or their strength or their sensation. Common side effects, after the procedure, this is the first month after the implantation, is you can have an infection, because that can go along with any invasive procedure. You can develop a kind of what's called a hematoma. You get a little accumulation of blood underneath the skin, and then you can also get what's called hydrocephalus, where you develop an obstruction, and that's 1%. It's a very small risk in a few patients. So who is a good candidate for RNS? We talked about with VNS. The guidelines are now from age 18 to 65, and you have to have disabling focal seizures. So if you have a little bit of numbness and a little bit of twitching, and it's not completely disabling, that person would probably not be a great candidate for RNS. One of the limitations is not having more than 2 seizure focuses. So we can't throw these electrodes at 3, 5, 10 locations where seizures are coming from. We have to really narrow it down. We have 2 focuses that we can impact. Or if you have one single focus, again, one single area where those seizures are arising from, in that eloquent area, and it can affect the motor, your ability to move, your language, or vision. Some of the advantages with RNS is it does not affect quality of life or mood. So the mood is the comorbidities of depression, anxiety are going to be much higher in patients with epilepsy. You're at an increased risk than the normal population. What we did find with RNS is there's actually improvements in quality of life, and we have a measure for that. It's the quality of life in epilepsy inventory, and it can, patients who have undergone RNS have over time noticed an improvement in that, and also some improvement in the cognitive domains as well. So this is just want to get a tabular perspective of that quality of life inventory in the first and second years after having the RNS implanted. And touching base on the complications, have the risk of bleeding in the brain, because we're putting something into the brain, so there's going to be a risk for that. Infection, as we discussed with any invasive procedure, it's about 3%. And you can have a little bit of memory impairment. What we found in the studies, though, is that about all the patients we had noticed that had the memory impairment, they all had some mild impairment before surgery. And then lastly, we have DBS. It's the deep brain stimulation. That was approved in 2018, and replacing electrodes deep into the brain in the deeper structures, and it delivers a continuous current that's predetermined. It's been set, and it simulates those areas in those deep structures. Again, this has the similar implantation for the generator, so the kind of the power pack that goes in the same place where you see VNS kind of above the left chest wall, underneath the skin. So this part's a little we're getting a little technical, but just to kind of summarize, we have what's called the anterior nucleus of the thalamus. That's a part of the brain that can at times be a generator for our synchronous electrical activity in the brain. And that's been very effective and the most well-studied. That's for the focal epilepsies. So focal, again, from one single source. We've also seen effectiveness, it's called the centromedian nucleus of the thalamus. It's a fancy way for saying we have this big structure, and there's different locations which we can implant the target for the DBS. And those are effective for people that have generalized epilepsy or a syndrome called Lennox-Gastaut. They've also looked at implanting other locations in the brain. It's called the hippocampus, kind of in the middle portion where we have our temporal lobes at the side of our heads. And we've seen that there's been some improvement with seizures coming from that region as well. And then also some small studies have showed some promise for another type of epilepsy called myoclonic epilepsy, where people can have these brief jerks and then they can progress and they can have the sustained seizures. So again, we're getting a little technical, but so you understand that we also understand the route and the proposed mechanism for how does the DBS work, and this is really related to the anterior nucleus of the thalamus. It's that region that we talked about before, and that's where we have the most robust data. And the idea is that it's blocking what we call depolarization. It's preventing those cells from activating. It's going to inhibit where the cells interact, and it can also, you press it and kind of tell it to simmer down. So talked about it's good for the anterior nucleus of the thalamus for those focal epilepsies, and then also those coming from regions along this circuit, the page circuit. So how effective is DBS? So in that first year, you notice about a 41% improvement. The second year, greater than 50% of people will have a 56% improvement. And like we looked at with the RNS, it can be seizure-free. 13% can have seizure freedom for up to 6 months. And then some can have seizure for at least 1 year, and that's the 7.3%. And even 3.5% will have seizure freedom for 2 years. It looks like a small number, but again, we're thinking about the impact on someone's quality of life, the way that they're able to have more, increase the kind of predictability of life, so to speak, because they're having that seizure freedom, they're able to drive again. These are all things that we kind of take for granted for those of us who have been fortunate enough to not suffer from epilepsy. So we have also noticed that it's as effective in people with epilepsy surgery versus those without, and that's with or without the vagal nerve or stimulator, because you can at times use more than one treatment. So for the DBS, again, we talked about the central median nucleus of the thalamus. We have smaller studies, but that indicates, again, over 50% of people will have improvement with the generalized epilepsy. So we have different target zones now. So we're not just kind of being limited to just one type of epilepsy. We can look at several. Who are our candidates for DBS? So you be 18 years or older. Again, you have to have the disabling seizures. Could be focal, and they can have what we call the bilateral tonic-clonic seizure. So we can have what's focal, where it's only originating in that one area, or it can be spreading, which can cause that shaking and throughout the body. And then it's useful also for those of us or those patients who may have more than one specific area where those seizures are originating from. So when we talked about the RNS, you can only have two or less, so 1 or 2 locus focus where the seizure originating from. In the case with DBS, you have more than that, so we can have several, 3, 4, and we're able to still have the same treatment. And then also for those patients that don't have a clearly identified seizure focus, we can't really identify exactly where those seizures are specifically coming from, and we have a treatment option there as well. So you're not a candidate for a surgical procedure and have part of the brain remove the resection, and we're not able to clearly say it's coming from this spot or that spot, and now we still have a treatment that can result in an improvement in the seizure frequency. Some of the complications with DBS is depression. So in studies we've seen that about 30% of patients who have DBS will report depression. One of our larger studies, about 2/3 of the people who reported depression already had a prior history of depression. So but it still is something that we keep in mind when we're looking at people, the treatment options that we're considering. Some people, about 8% had issues with numbness, tingling. There's again, like we saw with RNS as well, there's like some complaints of memory impairment. It may be subjective. We also have our neuropsychologists. I don't know who are with us, but they do a great job as far as really assessing that. In the studies that we have, again, about 25% of people with DBS will have some subjective memory complaints, but about half of those had already had a history of the memory difficulties. Of course, you can have pain where you have put in the electrodes, so you're going through the skull, pain there, and then also you have infection, like we said, with any invasive procedure. And then there were several what we call incidental brain bleeds, and that means if we weren't looking, we would have known it. The person was not symptomatic. They didn't have symptoms of a brain bleed. They weren't having any issues. Those are part of the follow-up, and they saw, oh, there happens to be bleeding here, and there was they didn't come in and were not able to move one side of the body or anything like that. So this is just a short kind of summary, full tabular selection here for the comparison between the different devices. And so going back to to summarize, we're looking at the people who have drug-resistant epilepsy, and then what is the type of epilepsy? Do they have to generalize where it's coming from? Two sides, the whole brain is activating together, or is it coming from one specific seizure focus, that one area? And then we're looking at what are the other options. So if it's what we say not localized, we're not able to say exactly where it's coming from, the VNS is a great option. And then if you have a very clearly definitively localized area where we know where the seizures are coming from, then we can proceed to the options between VNS, and we expand it to RNS or DBS. So like we had spoken about before with that RNS, if you have two seizure focus, or if you have one in what we call that eloquent cortex, RNS is an option. If you have more than three or more than two, and those seizures coming from non-eloquent cortex, we have the option of the surgery or the DBS. So thanks for your guys' time, and if you have any questions, we can discuss.
Great, thank you, Dr. Barr. We do have a couple of questions submitted in the chat so far. First one is, what happens to the wires of the VNS leading to the vagus nerve as a young child grows?
So that's an excellent question. There's going to be some flexibility within that, within the wires, and then the ability for us to kind of grow into it. However, if someone has, between being 6 years old and a fully grown adult, if there's any issues with the connections, the leads can be the wire can be replaced. You still are going to leave the electrode on the vagus nerve itself, but that's something that would be kind of each person specific.
Thank you. The next question in the chat is, are focal areas determined by observation in the hospital?
So that's an excellent question. When we think about our seizures, just from the outside coming in, what's the best part of the evaluation is it's getting the history. So someone's giving me a description of that, I'm able to, in my head, imagine where is the seizure coming from because of the features that they have, whether they have head turning, or they have trouble with words. We're starting to narrow it down. And then, so you don't necessarily have to be in the hospital for us to at least begin to isolate it in a certain region. And then when we've come to the point where someone has the drug-resistant epilepsy and we're looking at the surgical options, then they would come into the hospital for the epilepsies, to the level 4 epilepsy centers, where we admit you take off the medications and try to get a closer look at where exactly are the seizures coming from. We do that with a number of different imaging options. Of course, have the EEG, which is the brainwave test that we do, where we put the little sticky electrodes on the scalp, And that can help us narrow in at least to what we call an irritated zone. What is the irritated zone? That's the area we're seeing that some of that abnormal electrical activity, but that may be a little bit larger than exactly where it's coming from. And that's where we have the additional images that we use, like MRIs or functional MRIs. We have things called PET scans. And we're using all of these options to try to, again, narrow it down a little more.
Thank you. And the next question, do patients who get these procedures typically still need to take anti-epileptic medications as well?
That's an excellent question. So without it being a definitively curative treatment, then most patients will still need to be on the medications. However, that may also include that they'll be able to come off some of the medications, or the dose can be reduced. So we still have, we may not cure the epilepsy entirely, but we're able to improve things from the standpoint of, with medications you can have some side effects, but maybe someone's well controlled. So you're kind of trying to steal from Peter to pay Paul. And in this case, we're able to actually either come off some medications or reduce the dose.
Great. Does anyone here have a question? Can raise your hand. Not at the moment. Oh, here's one. How often, if ever, do these devices need to be replaced?
That's also an excellent question. It really varies per the circumstances. So they can be implanted. You'll need to at times replace the battery, that generator. But as far as having to replace the leads and those electrodes that are implanted into the brain, unless there's an issue with bleeding or some other concern, we can leave those in, and we have to change the battery pack depending on the lifespan of the different treatment we have. So VNS can be several years, about 3 to 4, and then RNS is often about 2 years. But that's just the battery pack.
I do have a question.
Ask away.
Dr. Barr, I do have a question.
Yeah, please.
Okay, when do you personally choose to use VNS versus DBS?
So that's a good option, a good question. So from my perspective, we're looking at some of the some of the comorbidities that we're dealing with. So if someone that they have depression, and that's something that is impacting them significantly, I may steer more toward the VNS route. I'm a fan of the DBS because, again, we're able to treat both focal and generalized or non-localized seizures. So we can VNS, like you were saying, they're equivocal in what they can treat, but the effectiveness and the responder rate is higher in DBS. So I like going with that side. If I was going to be flipping a coin, we got to look at the full picture, because it's not just looking at a coin.
Yeah, it's a little bit shocking because you would not expect to have that high rate of depression with DBS. So I agree with you.
Yeah.
That will be my choice.
Okay, thank you. And I see Dr. Zakaria has his hand up. If you want to ask a question.
Ask away, sir.
You're on mute.
Okay, so Dr. Barr, thank you so much for the presentation. That was a great discussion. I just want to mention that it's really exciting time for patients with epilepsy that we have all these options. And like Dr. Kitani was asking, which one is better? I think that will be a good discussion between the patient and the physician. I think that for the first time, we do have several options to offer our patients beside medications. And I want to also make the point that Dr. Barr and myself, we have a NeuroPace clinic at Memorial, which we try to include all the patients who either planning to get the NeuroPace, or they already had the NeuroPace and in the process of adjusting the setting of the device. We try to get them all together on the same day, once or twice a month. And in this way, we will not only have the discussion between as a physician and a patient, but also we will have the discussion between a patient and another patient. So if any of our patients today on this call, if they would like to reach out to another patient who already had the VNS and get his own or her own experience about the device and the expectation and what to expect from this process, please reach out to Dr. Barr or reach out to me. We have plenty of patients who will be more than happy to share their stories with you and get you to understand more what to expect, once you are ready for the procedure. But I think that was a great discussion. Thank you, Dr. Barr. And I want to thank also Epilepsy Florida for having Memorial and having us tonight. So thank you, everyone.
Yes, thank you as well for being on with us tonight and for taking the time to share your knowledge with us. Our next question is, does RNS only work if the patient has focal seizures?
So that's what we're using. We've been doing some studies now that have looked at looking at implanting specific areas within the thalamus that can target kind of a broader area, but for RNS, it still remains for focal seizures as far as what the majority of our data is telling us.
Thank you. And this next one is going to be a little bit of background information. It says, my daughter is on several anticonvulsants without stopping of seizures. The VNS battery needs replaced. She is now experiencing several mental health issues. Can this be related to seizure activity, medication side effects, or other conditions? And how can she have her evaluated?
So this is one of the best questions, because again, we're not just treating epilepsy. There's other conditions that can go along with it. So there's this kind of bidirectional, which means kind of two-way relationship between epilepsy and also mood disorders. So you're at about a threefold increased risk of depression, anxiety with epilepsy. Your question is good. Is it from the epilepsy, or is it the medications? Some of the medications, and again, this is why it's so important for us to evaluate and ask these questions that aren't always the most comfortable ones to ask. But some of the medications can either precipitate an underlying depression or mood disorder, or can worsen one. And so others can actually, we try to kill two birds with one stone at times. So we can improve seizures with some medications that also can be improve anxiety, can be used for treatment for depressions and different mood disorders. So the question of which one it is, we would need to look at the medications, get a little bit more of the history, and kind of go from there. And also, we have our baseline, predisposition, so family history as well. And you're asking, how can you have her evaluated? So, we're here. My information is a couple of slides up there, but you can always reach out, and we'll be happy to see you in our clinic.
Thank you. Yes, and Nirupa actually entered your contact information as well in the chat if anybody is interested. The phone number and the website is there. Thank you. Our next question is, do the devices prevent getting other procedures like MRIs, and do they show up in metal detectors or security scanners?
So that's, I like that, trying to get through the airport, and we don't want any more delays than we're already having. So they're appropriate. You can have MRIs with RNS and VNS. You have to turn the VNS off. With the DBS, it's not currently MRI compatible. And then the question of, do they show up in the metal detectors? If you have a little card that says you have your stimulator, it typically isn't gonna go off on that radar because it'd be swiping your head. But if it does, you can just show them your card and you're all set.
Thank you. And then the patient that we just spoke about a moment ago, wanting to know if the mental health issues were related to seizure activity or medication side effects or something else. They asked an additional comment, what about hallucinations?
So when we think about the different presentations with mood disorders, versus seizures, this would be something we need to dive into a little bit more in depth. So without casting out too broad of a line and saying it could be this, and speculating, it'd be something we would sit down and discuss more and see what the constellation of those symptoms are falling around.
Great, thank you. Does anyone else have a question?
Rachel, I just wanted to say something to add to Dr. Barr, not to be disrespectful, but for a patient, why it's a question about hallucination. Some form of hallucination can be seizures, so they are very important to be addressed to your physician so they could assess them. Are they hallucinations that are seizures or hallucinations because there's a mental issue or secondary to medication that are known to cause behavior issues? Just a little addition.
Thank you.
Yeah, I agree as well. That's again, without trying to slant toward one or the other. Exactly, you have to get a little bit better history to understand where it's coming from.
Thank you. Does anyone else have a question they'd like to ask? Okay, I do have another one that was sent in, and the question is, do you sometimes have patients that have two forms of neuromodulation? And if you do, is it common?
So sometimes we'll have people who will have a VNS, or they can actually, they can have a VNS and a DBS or a VNS. Some have already underwent the VNS because it's been around for a longer period of time, and they can have the RNS. One of the things we've also done is people can have actually a resective surgery, and then we'll also do the RNS as well. So those we can have kind of even including some people that are candidates for a surgery, but they're still having seizures. Sometimes it could be coming from what we call like the temporal lobes, those lobes of our brain along the side, like in our temples by name.
Thank you. And another question that was sent to me, this is regarding the RNS. I guess it could be for the VNS too. They're asking if you can feel the stimulation, or when it's happening.
I like the question, because this is like the practical thing. So like I said, sometimes I can get we get technical and we get all into where's the focus. Yeah, the simple things. We're talking about sending an electrical current into the brain. Am I going to feel that, and am I going to look like a zombie with the wires coming out of my head? So with the VNS, when it's giving that additional impulse because someone is detecting a seizure, or you're swiping the magnet because you're concerned someone's having a seizure, it can cause coughing because you're getting a stronger impulse to that region. For the DBS and the RNS, you would not feel that.
Thank you. We have another question.
Can I say something?
Yes.
My daughter feels hers, like literally every time it goes off, she can feel it.
So
she feels it.
Are you referring to the VNS?
Yes.
Okay. So the VNS, it's something we program it so we can change the current and how strong it is, how frequently it's sending that current out. And that's one of the things we have to adjust from time to time, is because we're making a balance. If the current is too high and they're getting discomfort from it, then maybe we need to go back down on it. But at the same time,
well, her seizures stayed controlled for quite a while, and then all of a sudden she started having seizures again. Like that was the first time she was almost 12 weeks seizure free since she was 9, and she's now 14. And she got VNS last year. Tomorrow it'll be a year that she got her VNS, and she feels it. And there's no turning it down.
So that would be something to be evaluated by your epileptologist. And there are again, it's programmable. So there are some ways to reduce it. And if you come to a point where you've reduced the current to it's not going to be effective, then the device could be interrogated and looked at is to see if there's a kind of a short circuit to make sure it's not sitting in a little bit of, or there could be some issues with the connection, like we have with any wires. And if they need to either replace some connections with the wires or the pack itself, they would just need to be looked at. So it's a bit of a broad, I'm giving you a broad answer because it's a broad spectrum of things that could be causing the cough. But it's worth getting it interrogated and looked at because, like you said, she has been seizure free. So we're looking at risk and benefits, but also the treatment can't be worse than the disease. So if she's, if it's that impairing, then you got to take a look at it and see what we can change.
Thank you, Dr. Barr. The next question is, do focal points ever show up years after an initial evaluation shows no focal point?
Depending on the, there's it's a bit of a broader question. So over time, some of those lesions can kind of manifest themselves. It really varies per person. Sometimes we won't see a lesion, and then we'll be repeating the images and monitoring, and we do see the lesion where we think the focus is coming from. But it also, you can have when I say a lesion, it's an area we have like a scar on the brain. But you don't want to get too caught up in whether if you see one and let that bias you as far as where the seizures are coming from based on, again, we all go back to the clinical history. And that's why it's so important to understand and communicate and ask those questions to get an idea of where in my mind am I thinking those seizures are coming from, and localizing it from there, and then pursuing it.
Great, thank you. All right, guys, we have just a couple of minutes left. Are there any last questions you'd like to ask? Anyone? Okay. Well, on behalf of Epilepsy Florida, I want to thank all of you for joining us this evening. A big thank you to
Rachel, I didn't mean to cut you. I'm so
Oh, that's
sorry.
okay.
I tried
That's
to
okay.
raise my hand and be polite, but I
It's
guess I
okay.
just have to interrupt. I just want to say thank you, Dr. Zakaria, for being here too, and for your time. Appreciate it. It's been a long time. And thank you, Dr. for your great presentation, very comprehensive and covered all neuromodulation. I would love to have some of my patients who have devices to reach out to your patient to talk more, because I do not have that support right here, right now. So thank you that you have that type of clinic or support group between patients who have neuromodulation.
Definitely,
Devices.
happy to help where we can.
Great, thank you. Okay, well, thanks everyone. I want to thank Memorial Neuroscience Institute for sponsoring us this evening. I want to thank Dr. Barr, Dr. Kitani, Dr. Zakaria, and Nirupa for joining us. And I hope that you all have a great evening, and I hope to see you again next month. Take care.
Thank you, everyone. We appreciate it. Have a great night.
Thank you.
Thank you again. Have a great night.